My title is Dr. Mark Tomlin. I'm a consultant pharmacist in critical care, which means I work most of my time with anaesthetists in intensive care and theatres. The COVID virus is a severe acute respiratory infection, which is abbreviated as SARS, caused by the coronavirus, in fact, the second coronavirus that we've seen. The virus activates the immune system and kickstarts the body to produce antibodies in order to kill the virus. It's a bit like the starter motor in a car. However, in some people, they're unable to switch off the immune system, and these people end up in intensive care with multi-organ failure. I think it's because many of the body systems are in homeostasis, where two opposing forces or processes are in a balance. I think one of the best examples of a homeostatic mechanism is the clotting cascade. And the one I thought would illustrate this well is the multiple steps in the clotting pathway, which are held in check by antithrombin 3, so that thrombi or clots are not formed where they're not needed. When we get heparin, we augment or enhance antithrombin C, and so tip the balance in favor of not clotting. So that's an example where the homeostatic mechanism is there and we push it one way or another. Okay, I think to really understand this, I'm going to go back 25 years or so to 1998, year 2000, when there was a new drug on the market called Centoxin. Now, the importance of this drug is that at the time, something like a third of deaths in America were due to gram-negative bacteria. So gram-negative bacteria are the ones which don't absorb the gram stain because they have an outer protein coating which stops the stain taking hold. Now, when you get a gram-negative infection, this layer is shed and produces an endotoxin response, a cascade of events which are inflammatory, which we see with gram-negative bacteria. And Centoxin was a human monoclonal antibody against this endotoxin. Now, what we learned from these trials was the importance of selecting the right cohort of patients. If you give Centoxin to patients with gram-positive sepsis, it doesn't work. More importantly, the patient's probably receiving the wrong sort of antibiotics as well, and I think that's crucial. The other thing about this trial is what was one of the first sepsis trial that clearly described the research definition of sepsis, because before then it had been fairly vague. And in fact, in many patients, sepsis was sort of flying blind. You didn't know whether you had a bug, let alone what kind of bug it was. And I think this is important because when patients get to intensive care, they're often passed through the emergency department, maybe onto a medical ward, and they may have received a number of antibiotics. The trial design gave us a clear definition of SIRS, systemic inflammatory response syndrome, which you get when you kick off this process. And then if you cultured a bug or had a very high suspicion that it was infection, that was one of the criteria for giving Centoxin, which was an expensive drug. And if we look at the sort of cascade diagram that we've got here, you start with pneumonia or some kind of chest infection, could be bacteria, could be fungus, could be a virus. And then in the case of gram-negative bacteria, you get endotoxin or exotoxin released. And then there's a whole load of pro-inflammatory markers or cytokines, TNF, tumor necrosis factor, platelet activator factor, leukotrienes, IL-1 and IL-6, and we're going to come back to those later on. Thromboxanes, prostaglandins, nitric oxides, a key component of sepsis, activation of complement. And then that goes on to latter stages, which are so-called counterbalancing anti-inflammatory mediators, light-activated protein C, like IL-10. That then produces edema, tissue injury, microvascular thrombi, which is going to be important in this story, and the inhibition of fibrolysis. And then these thrombi can go on to produce organ death. And that's the whole sort of cascade into septic shock. And that's what we really learned with Centoxin, was that pathway and a clear definition of where we were going. I think the other important thing for me about this study was it established the partnership between pharmacists and consultants in intensive care. Because really we had to work together to go through the criteria before we were allowed to use this expensive agent. And in my hospital, we treated 18 patients with this drug, and we had 12 survivors. Now, that could have been the drug itself, but probably we'd selected the right cohort of patients to get the right sort of antibiotics. Another hospital I know of gave 24 doses and only had 2 survivors. So we also learned that adherence to a protocol is important. Define your criteria, follow them carefully, get the right patients to get the right drug. And, you know, we had a clear definition of what we were treating. And I think that was really one of the importance of that study. If they move forward to about 2004, there's another study that I was very interested in called the Elephant Man trial, or infamously known as the Elephant Man trial. I always knew it as TGN 1412, which is a bit of a mouthful. So this was a study for a drug for cancer patients. Now, in cancer, we may have an inadequate immune system, and many studies have looked at how to boost this. But this particular drug took the brakes off the immune system so it could be fully activated and really have a florid response. However, instead of trialing it in cancer patients who are at the end of their treatment options, this was a first-in-man study, and it looked it was given to young fit males, those with a normal or even primed immune system, which I think was the wrong cohort of patients to try it on. And what we saw with these study patients was an unchecked super immune response with profound inflammation and edema. In other words, if you can't switch off your inflammatory response, you're in deep trouble. Again, it's the importance of choosing the right cohort of patients and the ability to activate your immune system, as well as switch it off or quench it after it's done its job. I think the immune system is a bit like a freight train. It's very slow to start, but once it gets going, it's very difficult to stop. An example of this would be cancer patients. They may have cancer because their immune system has failed to recognize the abnormal cells. Or they may receive later on treatment, which also knocks out their immune system. So they can't start the motor. They can't get the process going. And therefore, we have to shield them from the virus. And indeed, when these patients are in hospital, we often give them prophylactic antibiotics, antivirals, and all sorts of treatments to help their system, which has become immunocompromised. Other patients with autoimmune conditions, for example, rheumatoid arthritis, multiple sclerosis, inflammatory bowel syndromes, they have an imbalance with their immune system. And so their treatment is drugs which knock out their immune system because it's gone into overdrive. So this is where we get steroids, we get hydroxychloroquine, we get tocilizumab, anakinra, sarulimab, or inflammatory modulators. And this is really where the monoclonal antibody story has ended up. There are lots of treatments for these conditions. But if you've treated a patient, they are immunocompromised. So they are going to get secondary infections of all different sorts, which is why we're now shielding those patients so they're not exposed to the virus in the first place.